Good morning. Soon. Yeah. Do you want to start right away, Donna? And do you want? Well, we've got this up. Oh, sorry. You want to get something on?
Yeah, one that has the slides.
Oh, you want to pull?
Yeah, I want
that
to
up
take a
and
file off of there before we start. You can give me 2 minutes.
Okay. Well, I can put this one on as another alternative too. I don't know if we should do that or
It's okay.
what we should be doing. Let me double check.
Just give me 2 minutes.
Oh, sure. Let's see. Okay, this is joint side. That's MI. That's MER. C diff. There's this. Hey, good to see you. I think so. Well, I think we're either set up to do either one. And I think Charlie does have all the stuff on the other computer too, so I think we could do either one.
Okay, well, I'm not using slides today.
Okay.
So where's our stuff there?
Well, you can.
Go straight to the power.
Okay. Well, I think Charlie's set up so he can use the other regular one instead of the laptop if we want. But I'm not. Right now, it's on this one. Which PowerPoint are we having first?
C-diff. Yeah, because I'm not working on slides.
So if you want to do it from this one, see, right now it's on this one. Did you want the other slides?
Yes, show me our PowerPoint.
Oh, the one with the codes.
Yes.
Yeah, that is actually. Yeah. Okay. Okay, and I think Charlie has this one too. Okay, which slide is this?
It's the C-diff. C-diff is the first one.
Let's just check
Probably not really correct. It's okay. Should Okay, so when, and he'll switch it over.
He can switch it back and forth, yeah. So, okay.
Okay, well, I'm going to go ahead and start with the remarks. Okay, good morning, everyone. Welcome back. This is the second day of the ICD-10, yay, Coordination and Maintenance Committee. For those of you who weren't able to join us yesterday, there was a scheduling change for the auditorium, and we need to leave by the auditorium so it can be set up for a future event by 2 o'clock. So yesterday, CMS was able to do all its presentations, and we began the latter part of the day with at least 16 of the 24 proposals that we had for diagnosis. So this morning, we have 8 remaining presentations. They're the clinical presenters, and we will keep going until we get through the remaining 8 proposals as well as the addenda, and then we will end the meeting. And so thank you for your patience and understanding in the scheduling change, which was beyond our control. We know that it's inconvenienced several people with their travel and flight arrangements, and we do apologize, but it was beyond our control. These things do happen. So a few remarks, and then we'll get right into the proposals. Again, as everyone knows, no decisions are being made today. We ask that you send us your comments, your thoughts, your concerns about the proposals that are presented today, as well as the ones that were done yesterday. Of the 24 proposals total for diagnosis, only one of those proposals is being put forward by CDC as consideration for October 1, 2016, and that is the code for the Zika virus. All other proposals are being considered for October 1, 2017. However, there are some submitters of proposals that are asking for expedited consideration. That will be covered as part of that presentation for the proposal, and we do invite your comment on your consensus on whether something should be considered for October 2017 or whether it should be expedited and included in the first full update to ICD-10-CM effective October 1, 2016. The timeline is in your material, so I won't go through that other than to indicate that there is a correction that needs to be made in the timeline, and specifically, again, for diagnosis, with the exception of the Zika virus, all other proposals are being considered for October 1, 2017. For the Zika virus proposal, we ask that you provide comment to us by April 8th. For all other proposals that are considered for October 2017, we ask that you get your comments to us by May 6th. So we will make an adjustment in the timeline and repost the materials. And again, comments relative to those proposals that are being asked for early consideration, that you also get your comments into us by April 8th. I know a topic that is near and dear to everyone's heart is when is the addenda going to be posted? We're going to be posting information in a two-step process. Similar to what CMS has posted for PCS, we will be putting up a summary file with the diagnosis codes and titles that will show new codes, revised codes, and deleted codes. Because of a file glitch, those files will go up early next week. We have the file. We thought it was ready to go, and it wasn't. I don't know. I think between Mady, Hugh, and I, we think there are gremlins running around with our files. So we will post early next week. The full addenda, which includes the alphabetic index, the related tables, and the tabular list, will be posted within the usual time frame. However, if we can get it up sooner than that, we will, but much will depend on comments we receive about proposals from this meeting being included in the full update. So, but again, if you have further questions after you see the posting of the code numbers and code title files, you can send us a comment or a query back to the shared inbox, and we'll be happy to get back to you as soon as possible. CEU information, again, is available in your handout. And for those who are curious about the number of codes on the diagnosis side, since I know everyone was really curious on the CMS side as well. So in addition to the PCS changes of roughly 3,500, if I recall properly, for the diagnosis side, we're looking at about 1,900 new codes. And that would also include 313 deletions and 351 revised codes. But again, you'll see the entire file when we're able to post that. Let's see. Just by way of history, I know there were, we know that we had a much longer code set freeze than any of us anticipated. And so of the proposals that were warehoused over the last 4 years, that equated to 162 proposals. Yes, quite a bit. Interestingly, if you're wondering, why things are progressing as they are, there were a number of proposals that were presented early on in the cycle, for instance, 2012, and then in subsequent years during the freeze. Additional proposals came in and either revised what was already presented, others were withdrawn, others were amended, and then there were some that were very complex that required multiple representations, and most of you who follow the process know which ones those are. So you can understand that this has been a challenge with that 4-year freeze, trying to accommodate all the ins and outs and ups and downs. So we're very happy to know that ICD-10, CM, and PCS didn't blow up the world, it didn't fall off its axis, and all of the other terrible things that were predicted. So we're looking forward to returning to the normal updating process, which is having 2 meetings in a calendar year with consideration of those proposals for the following federal fiscal year. So some of the complexities that we experienced because of the partial code set freeze will hopefully now go away, or at least be very limited. So with that, I will close my remarks, and I'm now going to turn the podium over to Cheryl Bullock, who will lead us in the discussions of the next set of proposals. Cheryl?
Good morning. Our first presentation will be on C. diff, and we do have a clinical presenter, Dr. Andy DeReike, who is a Scientific Affairs Strategic Lead for Merck Research Labs. Dr. DeReike.
Thanks, everyone. While they're getting the slides ready, I'm so accustomed to talking to about C. diff at lunch or right after lunch. So it always seems to be a little bit different right after breakfast. But I have some pictures that probably will unfaze this crowd. But when I show it to family members, when they're seeing what I'm putting together, what is that? Especially the kids. So thanks for the opportunity to speak. The proposal today is just to bring more awareness of recurrent C. diff and why we're asking for a specific code in the ICD-10 codes to distinguish recurrent C. diff from first episode or regular C. diff. When I hit this, it changes.
Yeah, that's not the one. Let's try that.
Okay, thank you. Sorry. Excellent. Okay, and this is an example of the picture that I was I was talking about earlier. But this is a colon with a patient that has C. diff and the pseudomembranes that are classic for C. diff. But C. diff is a disease. It's often distinguished. The correct term is Clostridium difficile infection. Often it's called CDAD, or Clostridium difficile associated diarrhea. The preferred term is C. diff infection now, but known that 99% of the clinical manifestations are severe diarrhea. Patients who get C. diff have spores in their stomach. For some reason, when patients take antibiotics or chemotherapy, often it kills your protective normal flora, and some patients handle this with just a very asymptomatic diarrhea, don't seek treatment, they're just fine. Other people, particularly the elderly and patients with comorbidity, develop true symptoms of CDAD, often have to be treated in the inpatient center and are in an inpatient facility, and unfortunately mortality related to C. diff and the large estimates from the CDC are about 10% these days. In 2013, the CDC came out with the urgent threats list. From an infectious disease perspective, what was of interest is that C. diff was one of 3 urgent medical needs within C. diff. And I think many people are familiar with MRSA or MRSA or Staph aureus. And of note, that is not an urgent medical need with regards to resistance. Which is interesting because C. diff, generally people don't get better, or people get better, but then they recur. It's not really like other infectious disease where the organism that's causing the infection is resistant, or it resists the activity of the antibiotic. Usually the antibiotics that treat C. diff are just fine. They're not resistant. It's just even though we've done everything right with diagnosis and treatment, 20 to 30% of patients on their first episode of C. diff recur, even though we did everything right medically. There's a bunch of statistics for how prevalent and costly C. diff is. In the interest of time, and I know we're tight on space, I'm going to skip past for now. This is a nice schematic that shows the problem. On the left side here, you have 10 people that have an initial episode of C. diff. In the clinic, people don't say initial C. diff. They don't say acute C. diff. They just say C. diff or CDAD or CDI. So of these 10 patients, as I said earlier, even though you did everything right, you treated it correctly, it was promptly diagnosed, 2 to 3 people for their first episode of C. diff are going to recur. And what this usually means is on antibiotic therapy, which is usually about 10 to 14 days. They get completely better. Sometimes it takes till about 5 to 6 days to get better. And then they stop antibiotics. About 2 weeks later, they develop symptoms again. And the way I equate this is if you know anybody that has chronic pain, that anxiety about, well, I feel good when I take my medicine, but I know it's going to come back. How do we get rid of this? And I think many have, if anyone has Facebook, you've seen a post about fecal transplants, okay, or FMT, or where you take somebody's stool and you inject, it is what you think. You either inject it through, or you put it through the mouth, or you go the other side and you try to restore someone's colon, okay, with normal flora. Why is that so popular? Other than the ick factor, and it's interesting, and people send it, like, oh, have you seen this? Yes, I have seen this. Yeah. It's because of recurrent C. diff. Because even though we have treatments that are effective, recurrent disease is prevalent enough where it causes a problem. And it leads some patients, when they have multiple rounds of C. diff, it leads them to consider a fecal transplant. The other point I'd like to make is that, similar to MRSA, I can talk to anyone in my family who's not medically trained. They know MRSA. They get a cut. I hope it's not MRSA. They stub their toe. I hope I don't get MRSA, right? C. diff is coming to that point. We're all in the medical field, so we know of C. diff, but I bet everybody in the room knows at least one person personally that's had C. diff. That's what seems to be these days. From a healthcare resource utilization, C. diff is also a problem as well. And what I'd like to highlight is just the schematic on the left, that patients who get this recurrent C. diff, first of all, people that get C. diff, the average age in all the phase 3 clinical trials and all databases is about 66 years old. So it is a Medicare population that's predominantly associated with this disease. Well, what happens? When these patients get C. diff, maybe it exacerbates some other medical conditions and they have to seek health care. So there's this revolving door about they go home, they get a recurrence, they have to come back to the hospital, come back, or if it's a patient that is more stable, they go back to their outpatient physician, whether it's infectious disease or gastroenterology. And I've always contended that, at least for our company, C. diff affects every discipline of medicine. I even know cardiologists who are worried about C. diff, and I can think that's probably the furthest away in the medical discipline from C. diff, in my opinion. The reason why developing a new code for C. diff is important and can help estimate the true burden of recurrent disease is depicted here. And this was a study by an investigator in Boston at Massachusetts General Hospital. And what they did is they had people go in and for the last year, they went into all the charts and they determined who had recurrent C. diff. And then they decided, when they do analysis out of administrative databases, can we readily predict by administrative codes if the patient has recurrent C. diff or not? And what is shown here, and this is all you got to go back to the stats book every time to look at sensitivity, specificity, positive and negative predictive value. But the model, if you look at the top one there, it has greater than 3 ICD-9 codes for C. diff. And as you know, ICD-9 code 008.45 is the only one currently for C. diff, no matter if it's a first episode, a recurrent disease, multiple recurrence. A lot of times people put history of C. diff. They do that as well. But the sensitivity is 70% if they just use 3 ICD-9 codes. If you think about it, for recurrent C. diff, it should really just be 2. You had 1 episode of C. diff, and then you left, and then you get another one that's recurrent C. diff in the classic form. This was 3 ICD-9 codes, sensitivity 70%, which is true positives, which means of 100 patients that truly have recurrent C. diff, the use of 3 ICD-9 codes in administrative database is only going to catch it 70% of the time. That's not good enough. In this model, they also looked at other things that can be looked from administrative databases as well. They looked at ICD-9 codes, they looked at CPT codes for the stool test to detect C. diff, and they also looked for oral prescriptions for vancomycin, which is one of the common treatments for C. diff. And they found that even though they do all these together in an administrative database, it still has a sensitivity of 84%. The positive predictive value is only about 4 out of 10 patients for that test. So this is just one way that shows that the way they summarize the use of administrative data alone without individual case confirmation cannot be recommended at this time. This is one of the reasons we're asking for help, to really identify the true burden of recurrent C. diff, to distinguish it from an initial or acute, well, I shouldn't use that, to distinguish it from a first episode case of C. diff. Often in the charts, people put C. diff versus recurrent C. diff because it dictates different treatment. And it's in all the national guidelines, the 3 national guidelines that are the international guidelines, the US, the European, the ID, and the gastroenterologist ones in the United States, all distinguish first episode of C. diff versus recurrent C. diff. And we just asked for a code to help us understand the true burden of recurrent C. diff. Thank you.
Do we have any questions for Dr. DeWright? Any clinical questions? No? Thank you, sir. And if I could have the slide back to the laptop. There we go. Okay. For the code modifications, I would like to state that this proposal was originally submitted in September 2015 at the Coordination and Maintenance meeting. However, now modifications are being made based on public comment. And we've also had expert input for the clinical subject experts from the Center of the CDC, Office of Infectious Disease, National Center for Emergent and Zoonotic Infectious Disease. So we have the experts conferring on this topic. For our proposed tabular modifications, for category A04, other bacterial infections, intestinal infections, subcategory A04.7, 2 new codes are being proposed. A04.71, enterocolitis due to C. diff recurrent, and A04.72, enterocolitis due to C. diff not specified as recurrent. Those are the proposed changes. Any questions or comments? Thank you. Okay. Oh, I'm sorry.
I don't know if this is a clinical question or a coding question. I do appreciate the need to identify recurrent C. diff distinctly. I guess I'm just concerned about the word recurrent. I know every physician in this room documents perfectly, but all other physicians in the world do not. And I'm wondering, is there an alternate term for recurrent? I appreciated very much the specific definition that you gave us for recurrent, because that would let us know when we might need to query a physician if this is recurrent or not. But I'm wondering if there are alternate terms that we might see that we could equate automatically with the term recurrent. Come on. Sorry. Extra exercise.
Thank you.
walked all the way up here, the answer is no. No, what is usually used is they may say that there's another episode of C. diff or it's refractory. Sometimes they use the word refractory, but that generally means that the patient never got better. Their symptoms never truly went away. Where recurrent truly means that they were treated, all their diarrhea went away, or they went from 10 to 15 unformed bowel movements a day down to 2 unformed bowel movements a day. They were back to their baseline or well for a certain period, and then all the symptoms, the same type of symptoms came back. Okay. So generally it is not considered, it's either like they'll either say C. diff, they usually don't even say first episode of C. diff, they just say, oh, the patient has C. diff.
That's what I see, C. diff.
The patient has C. diff. But you know, what I would say is that because treatment modalities are different.
I understand very clearly why it's necessary to have a distinct code, and I do understand that the treatment modality and also the risks to the patient, you know, the morbidity and the mortality, that they do differ with recurrent. And I understand also that there are different medications that are used for an initial versus a recurrent. I'm just wondering, like, when I just see C. diff scribbled in a chart somewhere, well, keyed into a chart somewhere, if, like, the circumstances where I'm going to have to query that, or if I have to see the word recurrent to use the proposed code, so it's recurrent so stated, or a query. Okay.
Yeah, I don't think that this is going to be the fixer of everything, but just
It's
recurrent
better.
C. diff is so commonly stated on rounds and documented in the chart. It may not get every case, but it'll be a lot better than it is right now.
Okay, thanks, I appreciate it.
No problem.
Oh, okay, another?
Jeff Lancer, AAP. You bring up an interesting point about refractory C. diff. And so the patient isn't recurrent because it's ongoing first-time condition. And because the change in resource utilization and the extra services that may be required, would it be reasonable to add a code to indicate refractory C. diff?
Well, I see a lot of heads nodding yeah. That would be reasonable. Refractory is not used nearly as commonly in any of the guidelines or talk. It's more of a spoken word when people are in it. It's often, a lot of times, it's like with severe C. diff. When you say refractory, you got to really ask the person, what do they really mean? Because severe C. diff means a bunch of different things depending on it. But, you know, from my perspective, I'd be favorable of it. It's really the coders. I would seek input from the coding community on if this would create undue difficulties with identifying it versus if it's clear among the coding that it's recurrent or refractory. So
That'd be a good question for the zoonotic people.
thank you.
Thanks, Dr. Lenzer. We will take that back to our experts as well. The next two proposals were submitted by AAP. The first one is congenital sacral dimple, and it is found on page 20 in your packet. A congenital sacral dimple is an indentation present at birth in the skin of the lower back. It is a relatively common condition for neonates that may be benign in nature. Sacral dimples that are accompanied by a nearby tuft of hair or certain types of skin discoloration are sometimes and may indicate a more serious health issue, such as spina bifida or tethered cord syndrome. Currently, in ICD-10-CM, this diagnosis is an inclusion term under code category L0501, pilonial cyst with abscess, and L05.91 without abscess, which does not relate to this condition. The American Academy of Pediatrics requests a new code for this congenital sacral dimple. Tabular modifications. At code category Q82, other congenital malformations of the skin, a new code is being proposed, Q82.6, congenital sacral dimple, with the inclusion term of parasacral dimple. An exclusion 2 note is also proposed that will indicate the pilonial cyst with abscess, L05.01, and the pilonial cyst without abscess, L05.91. With these new proposed codes, there will be an excludes to note, respectively, under the L05 pilonial cysts and sinuses with abscess, with an excludes to, and L05.9 pilonial cysts without abscess. Any questions, comments, Dr. Linzer?
So this is really kind of a big deal because when a baby's found to have a sacral dimple, it can trigger a whole bunch of resource utilization, and the child may end up getting an MRI scan to see if they have an incomplete spina bifida or if they have a tethered cord or some other condition. This is very different than a pilonidal cyst, completely different types of conditions. So this is common enough that it's kind of been sitting out there, and actually we would like to add that this be considered for expedited addition to the 2016 version.
Thank you.
Jean Yoder, Defense Health Agency. We have about 45,000 births annually in our facilities, and this is a really, really important code because the pediatricians do an excellent job of documenting the newborn assessment. And we get so many times where the dimple's documented, and we've had to go back and train all of our coders over and over again. If there's no associated additional use of resources, meaning no diagnostic imaging, whatever, you don't code this thing. And so I'm really glad that it's here because it has caused us lots and lots of problems. So this is important code, and we certainly support this one.
Thank you.
My name is Corbin Williams. I'm with the American Academy of Neurology, with child neurology. And so I agree with everything what people have said. I just wonder whether or not to add more complexity, but whether or not we would make a distinction between a very simple sacral dimple, where it does not have that tuft of hair, where the base of the dimple can be appreciated, just because, like you said, if we have a simple congenital sacral dimple, it may not necessarily require those same resource utilization that we've talked about, versus if they do have clefts or some other unusual features about it that may warrant more further investigation. So just a thought.
Okay. Dr. Linzer, did you want to? No. Okay.
Jean Yoder, and I think this is excellent because you only code things that impact the episode of care. And if it's a simple little zit on the skin, I don't want to see it or have it in my coded documentation.
Thank you.
And I appreciate the comment, but I think that in common practice, this is the term that's used. We certainly could explore with our experts whether that could be a consideration for addition later on, but we think that here and now, this is the best solution and the most rapid solution.
Okay.
Sue Bowman from the American Health Information Management Association. I just wanted to follow up on the last couple of comments. Frankly, the records I've seen, we've seen at EAB, you're lucky if you even get the documentation of the sacral dimple, much less what type it is or that kind of thing. So I would not be in favor of having like multiple codes to categorize different types at that point. But to follow up on the other comment, there are actually newborn guidelines that are different from the adult guidelines that talk about coding conditions that may have future implications for health needs. So they don't necessarily need to be addressed during that healthcare encounter, the newborn encounter, to be coded.
Okay. Thank you. Any other comments? Thank you very much. And we will, again, take those, submit your comments in writing, and we will take all of those things in consideration as well. The next proposal, gestational autoimmune liver disease, is found on page 27 in your packet. Gestational autoimmune liver disease is a unique disease presenting as severe hepatic injury in newborn infants. Its onset is during the fetal development, and manifestations of this disease begin during fetal life. It is caused by a maternal antibody to fetal hepatic cells which crosses the placenta into fetal circulation, causing hepatic cell necrosis. Fetal liver injury often results in systemic iron overload, resulting in this condition as first being referred to as neonatal hemochromatosis. There is currently no ICD-10-CM code to identify this condition. Because of its clear perinatal origin, the American Academy of Pediatrics recommends that a new code be established in Chapter 16, Certain Conditions Originating in the Perinatal Period. It is noted that the pathogenesis and natural history are different from those specified in E83.1, Disorders of Iron Metabolism. The proposed code tabular modifications include, for subcategory P78.8, other specified perinatal digestive system disorders, a new code P78.84, gestational autoimmune liver disease, is being proposed, with the inclusion terms of GALD and neonatal hemochromatosis. There will also be an excludes note, which is an excludes 1, the hemochromatosis, E83.11. So the respective excludes modification will be also added to the E83.11, hemochromatosis with an excludes 1. Any comments or questions, Dr. Linzer?
So this is a condition very different than hemochromatosis that you'll see, for example, in adults. This is caused by maternal cells crossing into the placenta and essentially attacking the fetus's liver and causing it to dysfunction to the point that it will develop hemochromatosis. So this is a very unique and specific condition that needs a unique and separate identifier as we proposed.
Thank you. Any other comments? Thank you very much.
Just one point before we go on the proposal that AAP is now proposing for October 1, 2016, as opposed to 2017. Please make sure you get your comments in on that by the 8th of April. And again, we'll modify the topic material so that everybody has a reminder about that. So, okay, with that, I'm now going to turn the podium over to Dr. David Berglund, our medical officer, who will cover the next two proposals. David?
All right. And we will be next looking at classification of myocardial infarction. Those following in their handouts, this is on page 16 in the handout. And we will have some slides here. Let me pull this one up. And we will have Dr. James Chang presenting this. He is a fellow of the American College of Cardiology, a professor of medicine at Duke University School of Medicine, as well as being a member of the ACC and the American Heart Association Task Force on Clinical Data Standards, and vice chair of the writing committee to develop cardiovascular endpoints data standards. And he's very well respected in informatics as well as cardiology. And Dr. Chang, I'll invite you to come forward. You can tell us some more about yourself and tell us about the proposal we have. This proposal is related to classification of myocardial infarction. I will say up front that they have suggested that they would like to see this implemented this year, although the official CDC position is that we'd like to wait until 2017, but of course we are open to public input on this. So Dr. Chang, I will turn the podium over to you now.
Thank you very much, Dr. Berglund, and thank you for the opportunity to present to this group. Let me set the stage for this by providing a little bit of a clinical vignette to illustrate what the issue is. So a 28-year-old man presented to the emergency department of Duke a few months ago with pre-syncope, feeling like he was going to pass out, and his initial Vitals showed that his heart rate was 180. An electrocardiogram showed signs consistent with Wolff-Parkinson-White. He was referred to electrophysiology. They indeed documented and then ablated his abnormal conduction pathway. And he now is cured of this particular disorder. During the workup, a set of cardiac enzymes was obtained. They were positive for myocardial necrosis, myocardial injury, and he was labeled as having a non-ST elevation myocardial infarction. My question for you is, A, did he have a non-ST elevation myocardial infarction? B, should he be managed as if he had a non-ST elevation myocardial infarction? That's early referral to cardiac catheterization, multiple different medical therapies. C, should this label stay with him for the rest of his life? Did he have an MI? What about the insurance implications, et cetera? So let me walk you through three components here. The first is the history of the consensus approach across not just the United States, but the world to defining and classifying myocardial infarction. The second is a description of the current state-of-the-art as regarding that classification. And then the third is to set the context of this request. The first point is that there are now 3 different consensus groups, I shouldn't say groups, but different initiatives that have authored the classification of myocardial infarction. The first one, which occurred in 2000, importantly or critically classified any degree of myocardial necrosis in the setting of myocardial ischemia as an MI, as a heart attack. So that was really the starting point. In 2007, this was further refined to reflect not just the release of cardiac biomarkers, which had better sensitivity for detecting myocardial necrosis, but also advanced a classification scheme which has 5 different types of myocardial infarction embedded in it, which I will present to you in a few moments. The most recent update occurred in 2012, and this was prompted again by further development of the now highly sensitive and very specific biomarker, specifically troponin, in terms of the identification of myocardial necrosis. Let me move on then to the third universal definition of myocardial infarction document and the presentation of this classification scheme. The first type of myocardial infarction, spontaneous myocardial infarction, is what we all understand as a heart attack, and that is it shares the pathophysiology of atherosclerotic plaque rupture, ulceration, fissuring, spontaneous coronary dissection, or some process internal to the coronary vasculature that results in thrombus formation and then impairment of blood flow into the myocardial bed. This includes ST elevation acute myocardial infarction, non-ST elevation myocardial infarction, and the spectrum of disorders known as acute coronary syndromes. Type 2 myocardial infarction really needs to be thought of as an imbalance between supply and demand. The prototypic patient is the one that I presented to you, a person who has no other reason to have coronary artery disease, atherosclerosis, yet does have a reason for an abnormal supply and demand. In his case, his supply side was affected. When your heart is beating at 180 beats per minute, it really does not supply blood effectively to the coronary vasculature. And then he also has a demand problem. His heart's beating too fast. It needs energy in order to beat that quickly. Type 3 myocardial infarction addresses the conundrum of the patient who presents basically with cardiac or with death that most likely is due to a cardiac etiology where there isn't time to obtain these cardiac biomarkers. For especially research purposes, it was critical to understand that there are a group of patients who are manifesting a myocardial infarction where the initial presentation is death. Type 4 myocardial infarction is split into 3 different types. They're all related to percutaneous coronary intervention or angioplasty. The type 4A is probably the easiest one to understand, and that's something bad happened in the cath lab as you're blowing up a balloon or putting a stent in, and you have biomarker evidence of myocardial necrosis. Type 4B is the dreaded stent thrombosis sequelae of implantation of a stent. Fortunately, it does not occur all that frequently, perhaps around the 0.3 to 0.5% range, but we do have patients for a variety of reasons who return within hours to days and sometimes years after having a stent implanted where there's thrombus formation inside the stent. Type 4C is a restenosis phenomena where the patient presents. We know that they've had a stent implanted. We obtain cardiac biomarkers. Everything else looks fine, but their cardiac biomarkers are positive, and we classify that as also a myocardial infarction. And then the fifth type of myocardial infarction is myocardial infarction related to coronary artery bypass graft surgery, as we would anticipate that the stopping of the heart and the manipulation of the heart sometimes can result in some degree of myocardial injury. Importantly, the diagnosis criteria for type 4 and type 5 myocardial infarction related to interventions are different, at least at the level of cardiac biomarkers, than they are for type 1 and type 2 myocardial infarction. The last portion of my presentation is to establish some context. So the first question is, what's the prevalence of this problem of a type 2 myocardial infarction? There are a series of studies. One study from Denmark, for example, identified that about a quarter of patients who are diagnosed, who are coded as having a myocardial infarction, are actually having this type 2 myocardial infarction type of an issue, not a classic atherosclerotic quote-unquote heart attack. The treatment implications are listed up here. There's inadequate evidence currently regarding the treatment of these patients, but what is known is that the standards of care that we write in the guidelines that we've identified through the clinical trials process oftentimes are not applicable or potentially inappropriate. So this gentleman that I presented to you, my patient, does not need a beta blocker for life, does not need an aspirin for life, does not even need a cardiac catheterization. He did not have a myocardial infarction in the classic sense, that is a type 1 type of myocardial infarction. So the issues, the diagnosis, first of all, accurate and consistent coding is obviously critical, but the more important issue from my perspective is that for clinical practice, for quality measurement, for resource use, for reimbursement for services related to this type of myocardial infarction, that is specifically type 2 myocardial infarction, we don't really have a way to differentiate these patients from the ones who are having the classic type of type 1 myocardial infarction. It's also important in interpreting clinical trial findings, and right now, because we don't have a code, we actually hesitate to label it as a type 2 MI. We really don't know what to call these in the chart, and so most of the time they're labeled as a non-ST elevation MI. This affects all-cause 30-day mortality rates following acute MI if these patients are mislabeled, miscoded. It affects the calculation of 30-day readmission rates. It affects the payments and affects, again, resource utilization. In fact, I would again argue that oftentimes these patients are relatively mismanaged by excessive referrals for cardiac catheterization, et cetera, just to make sure that they actually do not have atherosclerosis. Thank you very much for your attention.
Do we have clinical questions? Dr. Linzer, I'll let you, please remind everyone who you are, just in case people don't remember.
Jeff Linzer, in this case speaking as an individual, but a member of the American College of Emergency Physicians. And I'm curious, at what level do you expect this detail to be diagnosed? Are you expecting the physician, the emergency department, to be able to differentiate these different types, as opposed to just STEMI versus STEMI, non-STEMI?
That's a great question. So my answer is that until you've gone through the workup, you would actually not know. I think at the emergency room level that your responsibility, and in fact what I would argue is that you should be diagnosing it as a myocardial infarction based upon the best available evidence, EKG, early return of cardiac biomarkers, and then referring on to cardiology to then differentiate whether it's a type 1, type 2, type 4, type 5. I would not expect the emergency department to be the appropriate place to do this. This is something that's cardiology specific.
So it would be the emergency physician would determine STEMI versus non-STEMI, admit the patient for observation, perhaps a treadmill, et cetera, and then the cardiologist or other specialist would then make the detailed determination?
Yes, sir.
Hi, I'm Linda Holtzman from Clarity Coding. I wanted to thank you, Dr. Cheng, for a very interesting and clear and relevant presentation. Thank you.
Thank you.
I do have a question about the type 4 and type 5. I didn't quite catch. You said that they are in the context of an angioplasty or a stent or a CABG, but I didn't quite catch, are they occurring during those procedures or are they after those procedures or both? Is this an intra-op, post-op, residual type thing? Does it happen 10 years later or? Because this has different coding implications.
Yes.
Which I understand is not necessarily related to the type 2 proposal, but I'm just interested to know. Thank you.
Yes, so a type 4A and type 5 myocardial infarctions are myocardial infarctions that are occurring as a consequence, an immediate consequence of the procedure. The diagnosis is not made until biomarkers return several hours later, but it is a consequence of the procedure itself. A type 4B, which is stent thrombosis, this is an event that the patient leaves the cath lab, everything looks beautiful, their stent is big and wide open, the interventional cardiologist typically hands the patient and their family a nice, pretty picture, and a day later or a year later or beyond, they return and they're having an acute myocardial infarction because a thrombus, a blood clot, is formed in the stent on an acute basis and now is occluding that stent. A type 4C myocardial infarction is an interesting classification. It reflects a group of patients who do not re-occlude their stent with a thrombus, but instead re-occlude their stent with atherosclerotic material. You would think that it shouldn't grow back, but sometimes it does. And some of those patients, when they're admitted to hospital, when cardiac biomarkers are obtained, they also are positive for myocardial infarction. So that's to handle those patients. Again, they're not having a classic type 1 or even a type 4B MI, and so there was a need to create that classification.
Nellie Leon, St. American Hospital Association. Thank you, doctor, for that presentation. We run a clearinghouse for people that need help with coding and so on. So we've been getting a lot of questions on how to code type 2 MIs and demand ischemia and so on. So we've got this lined up for our editorial advisory board for our publication to look at. I'd like to kind of follow up a little bit on your comment. I think I heard you say that some physicians are a little reluctant to document type 2 MI. Is it because they don't want to label them with the heart attack code? Because, I mean, I think that, I'm not sure how widely spread this is, but we are seeing cases that are coming into us where people are documenting that. They're also having, the coders are having these discussions with some of their physicians where they're saying, well, it's not really an MI, it shouldn't be coded as an MI. Could you sort of talk about that? I mean, is it that there's disagreement with the classification, or is there some other reluctance about not wanting to have it coded as an MI? I mean, because it is an MI based on that classification.
Right, so you've identified the very reason that we're here. And that is that there's a lack of clarity as to how physicians, how the clinical community should be documenting these events, and then by inference, an inability to actually code them to reflect the pathophysiology, and then to make sure that they end up as being counted in the right way. So reluctance is probably not the right word. If I use that, I would apologize. It's a combination of some degree of information exchange that needs to occur out in the community to actually start calling these type 2 MIs. And then perhaps the reluctance is because we know that if we write down type 2 myocardial infarction, we're going to get a query from our coders saying, now what do I do? Because there is no way to classify, to code these patients per this classification. So I can tell you within the clinical community, this is accepted. This is a national and international consensus from the European Society, from the American College of Cardiology, from the American Heart Association. There is no real question from the clinical side. Our dilemma is in terms of the documentation process.
But based on the existing classification, it does not distinguish the different types of MI. So are you saying that if the doctor sees the current acute MI code, they're going to cause problems for the code, or is that what's going on, do you think?
So I'm not sure I understand your question completely, but just let me provide you a couple of perspectives. First, if you see a positive cardiac biomarker and you write down myocardial infarction, that triggers a whole series of events that occur both in the hospital, referral for
Understand
cardiac catheterization, starting a medical therapy. And in fact, it isn't just that it triggers events, it triggers them fairly urgently. Go to the cath lab like right now, okay? So that's the type of response that is created. If you label this as a positive cardiac biomarker, kind of the term that we use somewhat provincially is that we use it, we call it troponemia, that they have an elevation of this blood marker in the blood, but it doesn't mean anything. And so then we are asked, well, are you sure this wasn't a myocardial infarction? And our reflection typically is, yeah, we believe this is a type 2 MI, and therefore none of the guidelines appear. But now the word myocardial infarction has appeared in the chart. And so this oftentimes triggers, well, this patient had an MI, so they should be counted in the rehospitalization for MI metrics, et cetera, et cetera. Yeah.
Okay, so it's all the downstream effects that would need to be handled manually or off the electronic record or so on as exceptions then, but it's not that there is disagreement that it is an MI.
Yeah.
It's just a different type.
Yeah, it's not
Thank you.
disagreement. It's the implications in terms of management, in terms of resource utilization, in terms of referrals, et cetera. Yes.
Thank you.
Jean Yoder, Defense Health Agency. I probably have my terminology all funny, but where's the infarct on a type 2?
Yeah, so if you go back to the 2000 Universal Classification document, basically the statement that was made is that if a biomarker is positive, a cardiac biomarker is positive, it reflects necrosis. The equivalent of myocyte injury equals myocardial infarction.
But I don't see a infarct. I see myocardial damage, but I'm just kind of wondering about the term infarct because there is no infarct. It just died.
Yeah. So you're bringing up a very critical nomenclature issue that is being addressed by the reconstituted Universal Classification Working Group. They are meeting today to deal with this, meeting now to deal with this. So perhaps if we meet together in a couple of years, we'll have a better nomenclature. But right now, we're calling it myocardial infarction.
Okay, so we're sticking with the old nomenclature, even though we realize that there probably was no infarct.
There's myocardial necrosis.
Right, got that.
Okay, so what do you call
okay.
myocyte damage, myocyte injury, myocardial necrosis?
Okay,
That's
never mind.
infarction.
I was just thinking, I'm missing the first step. Okay, never mind.
No, you're not missing it at all. The issue is that these are not the classic, you occlude an artery and now a whole portion of your wall is dead. These are, at the micro level, perhaps, reflections of myocyte injury, myocyte damage, that we can now detect with these very, very sensitive cardiac biomarker assays.
This is Kim Siri from Christiana Care. The struggle that we're having, similar to what Jean was stating, is that our providers are saying this is not an infarct. And I understand from a management perspective, if we add a code, it calls it out a little different, but I still think we are having the same struggle and having the word infarct there in the index when our providers are saying it's more of a demand ischemia. I'm not so comfortable with the wording. Right. Exactly. Yeah.
Yeah, so I'm reflecting what my colleagues have said is the nomenclature, and that is that they're calling these type 2 MIs. The nomenclature, admittedly, is imprecise.
Okay, thank you for all of that. As by way of comment on it, certainly I would say, based on the third universal definition that Dr. Cheng mentioned earlier, this is a type of myocardial infarction. Again, we do not have a full thickness infarction. We do not have probably the wall motion abnormalities that you would get with that. But it is still a type of myocardial infarction based on the current definition from 2012. And this does affect a lot of people. I think in talking with Dr. Cheng earlier, we may not know exactly how many people. It could be on the order of 100,000 people a year or something like that. I will be moving back to the other slides. Let me get back to that. And could we have the laptop slides back again, please? Okay, thank you. So in any case, this is an important issue. Currently, for coding MIs, we code most of these, of course, to category I-21. Right now, the title there has been ST elevation and non-ST elevation myocardial infarction. We are proposing to revise the title there and go back to, at I-21, acute myocardial infarction. That is actually restoring a World Health Organization title. So that is a part of why we would want to go back to that. We also are proposing to make changes that would affect the existing codes there at I-21.0, .1, .2, and .3 and .4. We're proposing to add inclusion terms. The first of these are ST elevation myocardial infarctions of different sites, anterior wall, inferior, other sites, or unspecified site. And we would add type 1 ST elevation myocardial infarction of each of the relevant sites for each of those codes as inclusion terms to make clear that these are type 1 myocardial infarctions. And then also at the non-ST elevation myocardial infarction code, we would add an inclusion term for type 1 non-ST elevation myocardial infarction. And there were questions on how you would be coding this right now, and it does depend on what's documented and how it's documented. But if we have a myocardial infarction definition, if we have the term there, then we would ordinarily expect that to be coded to one of these codes, probably to the I-21.3, which is where myocardial infarction NOS goes. However, that is an ST elevation myocardial infarction, and these are not ST elevation myocardial infarctions. So it's also possible people might use code I-21.4 for non-ST elevation myocardial infarction. However, a non-ST elevation myocardial infarction is also something else. This really isn't one of those either. On the other hand, we don't have other codes that we could appropriately say to use, and that makes it a little bit awkward. In the meantime, people will probably be using one of those codes, whether it seems appropriate or not, depending on exactly how this is documented. But that being the case, we're proposing to add, in this case, we were proposing to add a new subcategory, I-21.A, for other type of myocardial infarction. WHO likes to keep those fourth character digits for their own use, so, but we can use letters happily anywhere we want. So this is what we would propose to do in this case. And we would add within this new subcategory new codes, I-21.A1 for myocardial infarction type 2. And we would have inclusion terms there for myocardial infarction due to demand ischemia, myocardial infarction secondary to ischemic imbalance. These are some of the other terms that we could see used. We would also have a code also note there, code also the underlying cause if known, and with examples such as anemia, COPD, heart failure, paroxysmal tachycardia, renal failure, and shock. This is not meant to be an exhaustive list. In addition, we would add a new code, I-21.A9, for other myocardial infarction type. And this would include myocardial infarction associated with a revascularization procedure. It would include MIs type 3, type 4, A, B, and C, and type 5. We would also add a note to code also complication, such as stent occlusion, stent stenosis, stent thrombosis, or cardiac arrest due to an underlying cardiac condition, or complication of percutaneous coronary intervention, or occlusion of coronary artery bypass graft. So these are some of the possible things that might be coded also along with this. So that summarizes the proposed new codes here. And again, this was brought jointly by the American College of Cardiology and the American Heart Association, as well as we'd previously had a recommendation to add codes related to this that came from a couple of other organizations, but this proposal has been reviewed by the American Heart Association and by cardiologists there. And thank you, Dr. Chang, for coming and talking with us. Dr. Chang has, he's one of the people who helps write some of the things on joint statements that American Heart Association has out there, so we're fortunate he could come and explain this to us in some detail. Any questions on the codes here? Let me again say the American Heart Association and the cardiologists there did request that we implement this this coming October 1, 2016. We therefore would like comments by April 8. So I'd like to invite comments on the codes. And
okay, in the index, because if the providers don't want to write infarction because they don't think there was an infarction, but there's demand ischemia, if you look up ischemia demand, there's a non-essential modifier of coronary, and it says takes you to I-24.8, and that is other forms of acute ischemic heart disease. So is that where you folks at Christiana are putting all of this? Yes. Oh, okay, okay.
And I will say that you could have demand ischemia without having the, without having to the degree of having myocardial necrosis also. So there can be matters of degree for that kind of an issue. And I think our intent would be that if it's just demand ischemia without elevation of the biomarkers that show that there was actual necrosis and tissue was actually infarcted, then you would use the I-24.8. On the other hand, if you do actually have a myocardial infarction documented and basically the biomarkers based on that third universal definition that would support that, then we would expect it would be coded as an MI, even though it's not really fitting into either the ST or the non-ST codes. But given that it doesn't quite fit those codes, it's a little less than clear what will be done until we do add a new code for it. So, yes.
Sue Alderman, Mercy Medical Center. I just had a question about the subsequent MI codes. Are you going to make the same changes to all of those codes that you're making to these acute MI codes?
Good question.
Because you're going to have the same issues.
Good question. And at this point in time, we've not as yet proposed other changes there, but that is certainly something for us to consider. At this point, if it was a type 2 MI, I think we would be proposing just to use the code that we're proposing for it. But that certainly is another question. We had also had the subsequent MI codes while we've looked at those some. Those generally are for the other existing type, the ST or the non-ST types. And so we wouldn't be anticipating using or coding a type 2 or other types to the subsequent MI type. But certainly, and Dr. Chang, if you'd like to comment on that, I'll invite you to if you want. But would you like to come back up and comment on it? Or? Okay, that's fine. So yeah, we would propose that you would, even if you had another one within the time frame that would regularly be occurring, we would propose that you would use this code that we're proposing rather than a subsequent MI code for this type of MI. We might need more documentation to make that clear, Or we could expand there also. That would be another option.
Linda, hold
Now,
on.
Linda, let's go on, and
Okay.
I can hear that Nellie and Sue are wondering about how this would work too. But
Yeah, that's why I'm hesitating
certainly.
also.
Okay, go ahead.
Okay, no, I want to hear what they say.
You want to listen to what Linda and Sue are saying too there. Oh, boy. Okay.
Okay. Actually, Dr. Chang?
Well, I'll let you talk about this first, Dr. Zhang. Sure, go ahead.
Yeah, so let me provide one perspective regarding the previous question, and that is, what about subsequent MI? So a type 2 MI event is generally or typically a singular event. That you don't have the complications of a type 2 MI. Patients return for care of that type 2 MI because the problem is not myocardial. The problem is your lungs. It's even your electrical conduction system of your heart. It's not the vasculature. So if you have another type 2 MI event, first of all, you're really unlucky. But it would, the mainstay of our thinking in terms of dealing with these type 2 MIs is to ask the question, what's wrong with the patient? Not where's their problem in their coronary vasculature. So a second type 2 MI really would be another acute event. It really would not be a subsequent event. So, yeah.
Yeah. So, yeah, we would need to address that in the guideline, but I think the bottom line would be it would be appropriate to use the same code that we're proposing now for that, but we would need to make that clear in the guidelines that would be coded with the same code. It wouldn't be coded with another different code over at the subsequent MI code. And again, the reasoning behind this would be this is a clinical difference. It's not just a coding issue there. It's a real clinical difference. It's a difference in how we would see these people clinically, and there is a clinical reason behind why we would be proposing to code it this way. So, okay. Linda.
Okay. Well, first I wanted to say that obviously I agree with having separate codes for a type 2. I think it'll solve a lot of problems, probably create more, but it will solve some of those problems. Well, I mean, that always happens when we change things. But
there's always going to be new problems somehow.
Right.
Yes.
So as long as we all understand that. I just wanted to follow up on Jean's comment about demand ischemia. And so this is, and I will send this in writing, a formal request for indexing for demand ischemia. And that says something like, meaning AMI or whatever we're going to call it these days or in a few years. And likewise, instructional notes on I-24 that will tell us when you see demand ischemia, go here or go here, depending on what the interpretation of that is, what the meaning of that is. Which means you're still going to get queries, Dr. Chang. Sorry about that. And then my other comment is about the code also notes that are being proposed. I know a code also note the sequencing is determined by the circumstances, but I think it would help to have some kind of sequencing guidance on that. I'd kind of like to see a standard rule about which code should be sequenced first. Because there's an acute event going on here, and then it's got this underlying cause apparently. So I'm not sure code also is the exact right note. I got to think a little bit. Think through that a little bit more, but
we hadn't necessarily wanted to imply sequencing by these for a myocardial infarction that can be a major event and a major part of their problem. On the other hand, the other things that may be the underlying cause or might be involved with it may be more important, and depending on the circumstances of the admission, my thought was that it would be appropriate to allow the coder to decide which was the more important one based on the documentation in that case.
Okay, I'll run with it. So then my only other comment is just a slight concern for occlusion of coronary bypass graft with a T82. My understanding is that and also for stents, for that matter, if we're talking about progression of the disease, then I don't believe we'd be using a complication code. So that would need to be clarified in those code also notes. My understanding from Dr. Chang is that it could be a thrombosis, in which case we would use the complication, but if it's progression of the underlying coronary artery disease, that would not go to a T code.
So yeah, there may be some other things. We might potentially consider modifying that note, code also complication, if known or if applicable, or something to that effect.
If due to progression of disease.
Well, that's...
Sue Bowman from AHEMA, and my comment is actually really, really minor compared to all of the discussion we've just had, but it kind of relates to the code also note. Given all of these strange edits and strange interpretations of notes we've seen with the implementation of ICD-10, I would recommend we use the word any in front of complication so that someone doesn't think that, you know, you're always going to have a complication code with these codes. And I would just also comment that in light of all of this extensive discussion and the notes and the sequencing and the I-22 codes, I just do not think it's feasible to implement it this October and get this right. It's just too complex.
Okay. All right, we'll put all your comments in writing and let us know. We could be trying to do this relatively quickly if we were going to try to do it this October, definitely. But we do welcome public input on this issue, definitely. All right. And are there any other comments on either the coding or clinical issues with this? Seeing none, we will move on quickly. If there were more comments, I'm sure they would have had people coming up to the podium already. So next, we will be having a presentation on dermatomyositis. Those following along in the handouts, this is on page 21 of your handout. And I will be advancing the slides to the appropriate area, and we have another presentation, which I will move to. If I can find it. Let's see. No, that was not the one. You didn't want to tell us more about Clostridium difficile, did you? No, not really. Okay, let's see here. Hold on a sec. I do, well, we've got it here too, so that'll work. Okay, we will go back and forth between the other presentation. And we have here, Dr. Adam Schiffenbauer is here, and he is with the National Institute of Health, with the National Institute of Environmental Health Sciences, and also a member of the International Myositis Assessment and Clinical Studies Group. And I will let him tell you more about the group. And you can use that one and use this to forward or back. Sorry.
Thank you very much for having me here today to talk to you about dermatomyositis. So the reason we're here is dermatomyositis is an important disease to my heart and important to a lot of other people. That was in ICD-9. It's in the World Health Organization ICD-10 as a separate code, but isn't in the ICD-10 system at this point here. It's been replaced with dermatopolymyositis, which is a rarely used non-synonymous term. And then IMAX, the International Myositis Assessment Collaborative Studies Group, with support from ACR, as well as a group of other rheumatologists, neurologists, and dermatologists, think it's important to get dermatomyositis back into the coding system. So just for clinical background, dermatomyositis is a systemic disorder. It's characterized by chronic inflammation affecting the muscle and skin. It can affect other multiple organs, including the joints, lung, gastrointestinal tract. It can occur without evident muscle involvement, and that's been a more recent sort of thought in the process, dermatomyositis without myositis. It's a rare disease, but it's the most common of the acquired myopathies, and it is a treatable disease with ongoing treatment, although not curable. Polymyositis, on the other hand, is a separate but similar inflammatory disease that occurs in adults and juveniles. It has distinct biopsy findings compared to dermatomyositis, and it does not have the skin rashes that are associated with dermatomyositis. It differs in frequency of the clinical features, genetic and environmental risk factors. Pathogenic process is thought to be different here. The biopsies show different types of inflammatory cells when you go to the level of immune staining. The treatments can be different. The antibodies are different. We see autoantibodies that differ between the two diseases. And the treatment response differs from dermatomyositis. In children, there's a much bigger difference. Dermatomyositis in children, juvenile dermatomyositis is very common. Juvenile polymyositis is a rare variant there. And it has a wide range of prevalence estimates depending on where you are in the world and your view of it, going from 3.5 to 17 cases per 100,000. So there have been criteria for dermatomyositis and polymyositis since before 1975, but the one that's most widely used is the Bohan-Peter criteria from 1975. There are efforts to make new criteria, but they follow similar rules here, often inserting extra new criteria for that dermatomyositis without myositis to put it in there. And you can see that they are different diseases with different criteria, although there is some overlap there. This is in difference to dermatopolymyositis, which is an ambiguous term. A lot of work failed to turn up a agreed upon definition, either from experts in the field when we surveyed them or from the literature. In fact, if you go to Medline and you search dermatopolymyositis, it says you searched the wrong term and you want dermatomyositis or polymyositis. And it's not synonymous. It's used as a larger group, and that's how it's been used historically in the ICD coding system, is as a larger category that dermatomyositis and polymyositis then sit under as the distinct entities that somebody would code for. So I'm going quickly because I know we're on time today and people would like to have lunch at a reasonable hour. So those are the reasons why we think it's important for a difference here in coding, that this is really not a term you're going to see physicians putting in their charts. We have a lot of large epidemiology research studies, both in the United States and internationally, that differ, and we'll use dermatomyositis and polymyositis, and with this term you can't separate the two out. And it has differences in terms of treatment, how people would be managed. And that was it for me. Thank you.
Okay. If there were any clinical questions, we'd certainly be inviting you to come up. Not seeing any, we will move on to the coding side of this. I'll ask if we could have the laptop back up. All right. These are at M33 dermatopolymyositis. Again, that is a somewhat ambiguous term. The proposal here is at M33.0, we have, right now it's titled juvenile dermatopolymyositis, and we are proposing to change that back to juvenile dermatomyositis. And just looking at the subcategory M33.1, right now it reads other dermatopolymyositis, and we would propose to change that back to other dermatomyositis. And when I say we propose to change those back, I do mean we propose to change them back to what the World Health Organization has had for those titles. And those were changed early on in the process of creating ICD-10-CM. One of the things that historically we would wonder, why were they changed? And I'm afraid I don't have an answer to that question for you. It did happen before my time when I started here 18 years ago. So we know it happened very early in the process, and we did try to look back at some of the documents for that. So far we've not sorted out exactly why. We may not be able to tell. The bottom line was that for some reason these code titles were changed, and the experts in this area, Dr. Schiffenbauer, and others would like us to change them back. So we are proposing to do that. At the same time, we're also proposing to add some new codes. So looking more specifically, we have existing codes at M33.00 for juvenile. We'll change it to, propose to change it to juvenile dermatomyositis for organ involvement unspecified. For .01, that's with respiratory involvement. .02 with myopathy. And the existing .09 is with other organ involvement. We are also proposing to add a new code, M33.03, which will be juvenile dermatomyositis without myopathy. We're also proposing at M33.0, we'll be changing that, is proposed here to other dermatomyositis. We would add inclusion terms for adult dermatomyositis and also dermatomyositis NOS. That's just to clarify that this is the appropriate place for these. The adult isn't listed right now, but dermatomyositis NOS would be indexed here, and we would propose to add it as an inclusion term also. Again, we have similar codes here. The M33.10 is the other dermatomyositis organ involvement unspecified. We would be changing the title to be dermatomyositis. And the 0.11 is with respiratory involvement, 0.12 with myopathy, and 0.19 with other organ involvement. And we would also propose to add a new code, M33.13, for other dermatomyositis without myopathy. It's also proposed that at M33.9, dermatopolymyositis unspecified, we would propose to add a new code, M33.93, dermatopolymyositis unspecified without myopathy. So these are types that are without myopathy. We did also ask whether we should consider adding one for polymyositis without myopathy, and Dr. Schiffenbauer said that does not occur, so we would not propose to do that then. But for consistency, we would add that at the other areas here. So that's the proposed coding changes. Any comments, questions?
Sue Bowman with HEMA, and I'm a little confused because it looks like the only place we've kept dermatopolymyositis is at the M33.9, which we claim doesn't exist. So I'm not sure when that code is going to be used. I mean, it seems strange to say unspecified dermatopolymyositis when we don't have any dermatopolymyositis through the whole rest of the category.
Well, it's a sort of catch-all term that sort of includes both the dermatomyositis and the polymyositis, but the term really isn't used in clinical practice as I understand. And well, Dr. Schiffenbauer is the expert on this, and that's what he tells us. But we would keep the term just in that it is a WHO code also, so it's sort of a catch-all unspecified code at that. But we would probably not expect to see it used much, as you say.
And dermatomyositis unspecified without myopathy would go to M33.13?
Yes.
I think that might be a little bit confused with M33.93, where some people might think it goes there.
Well, if the documentation said dermatopolymyositis, it would go to the 0.93. If they just said dermatomyositis, it would go to the 0.13.
I'm just not sure it's entirely clear the way it's worded now, and it just seemed kind of odd that that one word was sort of left hanging all by itself at the end of the category.
Well, the dermatomyositis would go to the 0.1 unless it was labeled juvenile, in which case it would be at the 0.0. And the term dermatopolymyositis would go to the 0.9. And polymyositis would be at 0.2, which we don't show because we wouldn't be proposing to change it at all. Dr. Linzer.
Jeff Linzer, AAP. On the face of it, I think that the Academy can support this proposal. I don't see a problem at the M33.9 since the M33 category is dermatopolymyositis, that you're just playing catch up with that there. One of the comments I would like to suggest to the cooperating parties when they are looking at revising the guidelines, and this is an issue that has come up when the term juvenile is used. Some entities want to put an age limit, even though the term juvenile may apply in an older patient just because of the type of condition it is that it meets certain categories. So it would be helpful in the guidelines if there was a comment that just because the term juvenile was there, that it didn't have an age associated with it.
Okay. So basically, we'd be looking for the term juvenile, and we wouldn't be looking at the age. I think that would be the case, yeah.
Nellie Leon, St. American Hospital Association. I want to follow up to Sue's comment earlier. The dermatomyositis NOS inclusion term applies to the entire subcategory M33.1. But if I don't have anything else, then I have to pick out of that entire subcategory, and I don't know which one I should go to. I think that was her point, that normally the unspecified would go to one of those codes that would say unspecified, but right now I'm having to figure out, well, is there a default, is organ involvement my default, is myopathy my default, or which one? So I think that if you want to have an NOS, you kind of have to actually tell us which one of those codes it should be.
Okay, and yeah, the 0.10 should be the NOS, organ involvement unspecified. So we could move the dermatomyositis NOS down to the 0.10. That could be more clear then. Okay. Any other comments or questions? All right, seeing none, we'll be going on. Thank you, Dr. Schiffenbauer. And we'll be next, I'll pass it back to Donna, and we'll I will let her tell you where we're going from here.
Yes. Shannon McConnell-Lamptey will now take the podium and present the next 3 topics. And 2? I've lost track. Is Dr. Repka here? Okay, so, yeah. Okay, what we're going to, one of our presenters isn't with us yet, so we're going to change the order a little bit, so bear with us. But Shannon will be the next one up at the podium. Shannon?
Good morning. I'm going to change the slides. Okay. The next topic is on page 47 in the topic handout. The topic is pediatric cryptorchidism. When treating patients with an undescended testicle, it is important to determine the specific location of the testicle, as it could have important implications for follow-up and treatment. More specifically, it is important to document the various locations where an undescended or ectopic testicle is found. Intra-abdominal, within the inguinal canal, high scrotal, or ectopic. In addition, a child may frequently be sent for evaluation of a non-palpable testicle, which in itself requires further evaluation to determine the location and presence or absence of that testicle. Currently, ICD-10-CM has unique codes for abdominal testicle, ectopic, and ectopic perineal, and codes for unilateral and bilateral. However, more specific codes are needed for accurate patient description, such as inguinal undescended testicle, high scrotal undescended testicle, and non-palpable testicle. The American Urological Association proposes the addition of new codes in order to identify these conditions. The proposed tabular modifications are at category Q53, undescended and ectopic testicle, subcategory Q53.1, undescended testicle, unilateral, to add a new subcategory Q53.11, abdominal testis, unilateral, with 2 new codes, Q53.111 for intra-abdominal and Q53.112 for inguinal, and to add a new code, Q53.13, high scrotal testis, unilateral. At subcategory Q53.2, undescended testicle bilateral, to add a new subcategory Q53.14, Q53.21 abdominal testis bilateral with 2 new codes to read Q53.211 intra-abdominal and Q53.212 for inguinal. Also adding a new code Q53.23 high scrotal testis bilateral. And at category R39, other and unspecified symptoms and signs involving genitourinary system, subcategory R39.8, other symptoms and signs involving the genitourinary system, to add 2 new codes, R39.83, non-palpable testicle unilateral, and R39.84 for non-palpable testicle bilateral. And we do have Stephanie Stinchcomb here in the audience. She's with AUA. If we have any clinical questions, she may be able to address those. So are there any clinical questions?
Jeff Linzer, AAP. I can't believe I'm saying this. Well, first of all, I think it's very good on the face of it, the proposal. But with the unilateral, I think that it would be reasonable, since we're looking for the detail, to add laterality.
To add that, okay.
So at the Q53.11 and at the R39.83 to add laterality.
Okay, thank you.
Nellie Leon, St. American Hospital Association. This may be partly a clinical question, partly a coding question. So for the abdominal testis, is it ever possible that you would not know whether it's intra-abdominal or inguinal? Let's say you haven't done further exams. It seems like you would need an unspecified option for those.
Okay. I think that would be a good, Stephanie's actually shaking her head. That sounds reasonable to have the unspecified? Yes. Okay. Thank you. Okay, if you'll give me a chance. Oh, Dr. Linzer?
You know, the only problem with the unspecified is, I agree with Nellie, you're not sure of the location, but this, when there's so much detail available and you put in unspecified, a lot of people are getting really hinky on this. And I'm wondering if you have an unspecified, but if you had some other term of, you know, like location undetermined, I'm not sure what would be the right term, but something other than unspecified, just to indicate that it's...
Can you stand up, Stephanie? I can't hear you.
It's in the neighborhood, but we're not exactly sure where.
I think maybe, this is Stephanie Stinchcomb, AUA. I think probably we should probably look and see like an undetermined location or some wording to hit that, because that is true. I mean, you've got to really do some more investigation, more examination of the patient, okay. And you know, sometimes you might not be able to determine. So maybe we can work together on that.
Okay, the terminology.
Sue Bowman from AHEMA, and I understand Dr. Linzer's point, but I'm not sure undetermined location is a good alternative, because that means that the physician has to document that he can't tell where it is, as opposed to the specific site just not being documented. So that's going to increase a lot of queries and a lot of angst and that kind of thing. So I think that might have unintended consequences of causing even more problems.
Okay, thank you.
Just want to make sure the coder
Okay. So the next topic can be found on page 10, and I'm going to go ahead and locate that with the slides. Okay, so on page 10, the topic is abnormal levels in urine collection. This too is a proposal from AUA, and they are proposing the creation of new codes for specific abnormal findings in urine collection. One of the most commonly used diagnostic tests for patients who form kidney stones is a urine collection looking for abnormal levels of certain substances so that abnormalities can be treated to reduce the risk of future stone formation. For example, patients with high levels of urine calcium may be treated with thiazide diuretics. Those with high levels of oxalate may be treated with dietary changes and medication. We currently have an existing code in ICD-10-CM E72.53, hyperoxaluria. It is for a childhood inborn error of metabolism, which is a diagnostic condition that can be determined by genetic testing. This is different than someone who has an idiopathic or diet-induced mild elevation of oxalate in the urine. To better capture the unique characteristics of these abnormal findings and to help with research, AUA is requesting the following ICD-10-CM tabular changes. The proposed tabular modifications at category R82, other and unspecified abnormal findings in urine, subcategory R82.9 at code R82.99, other abnormal findings in urine, to add and excludes 1 for the primary oxaluria at the code which is at E72.53. To delete the current inclusion terms, cells and cast in urine, clerosteria, and melanuria. To add the following new codes, R82.991, hypocyturia, R82.992, hyperoxaluria, R82.993, hyperuricasuria, R82.994, hypercalciuria. At R82.998, other abnormal findings in urine, with the inclusion terms cells in cast in urine, clerosteria, and melanuria. Are there any comments or questions on this proposal?
Nellie Leon, she's in AHA. I would recommend that we be careful with the use of the excludes 1 notes because it can get us into trouble, as we've seen. So someone could have primary hyperoxaluria. I was going to have to pronounce it. But they could also have some other abnormal findings in the urine, the R82.998. So if you have that excludes 1, you could never have anything else abnormal with the urine. So I would say make that a excludes 2.
Okay. Thank you.
Or the other option may be to put it under R82.992, because I think that you should not have both.
Right, that is the one that it crosses over. Thank you. Any other comments? Okay, I believe, Tracy doing agenda? I'm going to turn the podium over to Tracy Ramirez.
For those that are following along, the addenda begins at page 59. Okay, so under D68.62, we're revising the code in the excludes 1 note from R79.0 to R76.0. At code I50, heart failure, we're revising the excludes 1 note to become an excludes 2 note, cardiac arrest. At K76, we are revising the code under K76.7 that excludes one note under post-procedural changing it from K91.82 to K91.83. And the next note is we're showing a modification from the September 2015 meeting. This note was presented as a topic then, and due to public comments received, we are showing this in the addenda to show basically what the final result from all the comments are. So we're showing it as part of the addenda to show you what the final result will be. At PO7, under disorders of newborn related to short gestation and low birth weight, not elsewhere classified, we're removing the excludes one note underneath the category and putting it under the subcategory for each code at P07.0 and P07.1. At the section level of signs and symptoms involving the digestive system and abdomen, we are revising the excludes one note. There was a typo that had male in there twice, so we are removing that. And at code R13, aphasia and dysphagia, under R13.1, there was a typo, there was a comma that's way far out there, so we're moving it back in. And at code S00, superficial injury of head, S00.8, we're adding an inclusion term, injuries of face, any part. And at T80, complications following infusion, transfusion, therapeutic injection, we are adding a code also note to code also arthropathy and hypersensitivity reactions, classified elsewhere, if applicable. At Z12, encounter for screenings for malignant neoplasms. At Z12.4, we are revising the excludes one and making it an excludes two note for the encounter for screening for human papillomavirus. And at Z95, presence of cardiac and vascular implants and grafts, we are adding an inclusion term for presence of coronary artery bypass graft. And at Z79, Z79.8, Z79.81, the code first note, there's also an error with the comma. It needs to be moved over. Then we're showing that here. I guess. Okay, I guess the addenda is not, the index is not on here, so. You guys have it in your packet. It's on page 61. At bacteriuria, I don't think it's in here.
You can bring up the PDF.
Okay, sure. I must have. There you go.
So
Okay.
You can just scroll.
Yeah. Okay. Thanks, David. Okay, under bacteremia, we are adding a subterm asymptomatic, and we're revising the code there from N39.0 to R82.7. Under bursitis, we are adding subterms for collateral ligament tibial. We're adding the code number M76.04, as well as tibial collateral M76.04. At clot, we're revising the subterm for non-resulting in infarction from I-24.0 to I-51.3. At delayed, we're revising the code number from R62.50 to R62.0. We're also revising the subterm global and the code from F88. We're adding psychologic, and adding the code R62.59. We're adding the subterm milestone with code R62.0. We're adding psychological, and we're revising psychological and adding NOS at R62.50. Under disorder, we're adding a subterm for acute at F43.0. And this next item is actually a typo that should not be on there, so when we post the updated version, we will strike that off. So just disregard that one. Next is lesion. We're adding a subterm, we're revising the subterm on the cardia with the code from K22.9 to K31.9. Under metaplasia, we're adding a subterm for esophagus at K22.7. We are revising the code number at Minamata disease from T26.1 to T56.1. And at scoliosis, we're revising the subterm adolescent idiopathic C scoliosis idiopathic, and removing the word juvenile and adding adolescent. At thrombosis, we are revising the code at non-resulting in infarction from I-24.0 to I-51.3, as well as under cardiac, non-resulting in infarction, changing it from I-24.0 to I-51.3, and under endocardial, non-resulting in infarction, I-24.0 to I-51.3, and under heart intramural, non-resulting in infarction, I-24.0, we're revising to I-51.3, as well as under mural, non-resulting in infarction to I-24, from I-24.0 to I-51.3, and under ventricle, see also infarct myocardium, revising the code from I-24.0 to I-51.3. And I believe that is it. These changes are all being proposed for the October 1, 2016 addenda to be included in the October 1, 2016 addenda. Any comments or questions?
Nellie Leon, she's saying the excludes one note that was on the tablet, kind of like the very first revision that you were discussing, where you were taking out the extra word male.
Yes.
Okay, make that an excludes two-note, because the way it is now, you could not have a symptom related to a male genital organ and also have like a tummy ache or something else that may not even be related to that, because this makes it like you can't ever have anything wrong with a symptom with the genital organs and something wrong with the digestive system.
Okay.
Hi, Laura Evans with Decision Health. I'm seeing a typo here under delayed. It looks like a combination of physiological and psychological, the second from the bottom.
Okay, yeah.
Is that going to be psychological?
Yes.
Is there going to be a code associated with it?
Yeah, we will add the code to it.
Okay, thank you.
Thank you for pointing that out. Any other questions or comments? Okay.
Okay, our final presenter is here, so Shannon will come up to the podium to introduce our next speaker and the proposals. Shannon?
Thanks, David. Okay, so the next topic can be found on page 12 in the topic handout. The topic is blindness and low vision, and with us we have Dr. Repka here to speak on behalf of the American Academy of Ophthalmology, and he will provide the clinical background. Yes, if you'd like to come up and provide the clinical background.
Here or there?
Oh, here.
Good morning.
Good morning. This proposal was brought forward by low vision specialists who have noted a difference in way they could report low vision services to beneficiaries and patients and clients after the change to ICD-10 from ICD-9. In fact, one of the few places where the system went less granular in this system. Now, the proposal takes what was pre-existing in 10 and builds off the WHO recommendations for categories of visual impairment. It further decides to look at the patient both as a patient as well as by eye. In the current ICD-10, it's very difficult to tell where a patient is moving, if they're moving at all, because the system lumped vision impairment categories 2, 3, 4, which are WHO categories and already exist in ICD-10, as well as in ICD-10. They did not change. This protocol then just simply takes it and says, well, I want to be able to view what happens to a patient in terms of their low vision, and I'm interested both as a patient and as an eye, and it uses the conventions of right and left, unspecified, and then walks through that patient. And so the example here is that a patient with blindness and low vision, as shown in the example, might be age 54. And what we've done is we added 3 digits. In this particular example, a placeholder in position 5, and then digit 6 and digit 7 representing the right and left eyes. So again, you could not do that in the current system. And what the coder is going to do is for the right and left eye, they're going to put the WHO category of vision impairment. And that would allow, from visit to visit or time to time, to see change in the category of vision impairment for each of the eyes, so to be able to track that. From a practical perspective, a number of the MACs have looked at coding and simply want to see a change to support low vision rehabilitative services. And so for practical purposes, this would allow them to do that, to be able to show the payor that in fact there's been a change, either negatively where service might be beneficial, or positively where in fact the patient is getting better. So again, digits 6 and 7 build off of the current categories that lump, well, the categories in the system. The current ICD-10 lumps categories 1 and 2 and 3, 4, and 5 as either partial blindness or total blindness. So we're basically expanding, and it's a particularly large expansion. So I have certainly understand that it's hard to understand. It certainly took my careful explanation with staff several times to get them to see what I was thinking of in this proposal. On the other hand, maybe one of you can do it better or more succinctly. Shannon?
Thank you, Dr. Repka. So I'm going to go through the tabular modifications. Do we have any questions first for Dr. Repka from the clinical side before I go through the tabular modifications? Okay. So the proposed tabular modifications are at category H54, blindness and low vision. We will be adding a new subcategory, H54.0, blindness both eyes. With this new subcategory, there will be 9 new codes to capture the different iterations of blindness, the right eye and left eye combinations for the visual impairment categories, 3, 4, and 5 in both eyes. Again, the intent being to code the severity of each eye separately. We will be adding a new subcategory at H54.11, blindness right eye, low vision left eye. This would bring the addition of 6 new codes to capture the iterations of blindness, right eye, and low vision left eye combinations. Again, using the visual impairment categories, blindness, 3, 4, and 5, low vision categories 1 and 2. At the new subcategory, H54.12, blindness left eye, low vision right eye, there would be similar new codes. We would also be adding a new subcategory, H54.2, low vision, both eyes, with 4 new codes to capture the different iterations of low vision, right eye, left eye, combinations again for the visual impairment categories, this time only being categories 1 and 2 in both eyes. And adding a new subcategory at code H54.41, blindness, right eye, normal vision, left eye, with the following new codes. H54.413A, blindness, right eye, category 3, normal vision, left eye. H54.414A, blindness, right eye, category 4, normal vision of the left eye. And code H54.415A, blindness, right eye, category 5, and normal vision, left eye. Similar new codes would be at a new subcategory, H54.42, blindness, left eye, normal vision, right eye. Okay. And at subcategory H54.5, low vision, one eye, unspecified eye, we would have a new subcategory at H54.51, low vision, right eye, normal vision, left eye, with the following new codes. H54.511A, that being low vision, right eye, category 1, normal vision, left eye. And code H54.512A, low vision, right eye, category 2, normal vision for the left eye. Oh no. And this is actually the table from WHO, but those similar codes would also be provided at the new subcategory H54.52. And again, showing the table with the actual impairment categories. Are there any questions or comments?
Nellie Leon, she's saying AHA. I know that one of the benefits of ICD-10-CM were these combination codes, but I wonder if this is more complex than it need to be, having heard many physicians before complaining about too many codes and so on. And it makes it hard to read and kind of go through and pick. Okay. So I wonder if it would be simpler to just have separate codes to indicate the categories of blindness. So for example, blindness, right-eyed category 3, blindness, right-eyed category 4, and then separately like that for left eye. And then that way you could have the existing codes and say, have one that says blindness, both eyes, code also separately the categories for each eye if known. And then that could be applied across the different ones that have these combinations of one eye normal, one eye blind. And then similarly for the low vision, have the categories be either separate codes or and I can't believe I'm saying this, seventh character identifying the category. Because I know that I initially had problems saying, we've been teaching that seventh characters are only in the OB chapter or the injuries chapter, and they represent initial, subsequent, and so on. But we've sort of gone past that, and we've created 7 characters in other areas. So if it was easier to put it as a 7th character, it would be easier to read and display in the tabular list. But I'm just afraid that just looking at this on a tabular list, and granted, you're not supposed to code off the tabular, you start off in the index, but I think it also would simplify the indexing of these categories.
Yeah. So let me try and address that. Some of the current codes actually already do that, meaning if you code to 5 levels, you actually get exactly what you want, which is a per patient. We really need to have both a per patient and a per eye. And while I acknowledge the per patient would be what most people use, and frankly I think that's to some extent already in ICD-10, it's the per eye change.
No. I'm not objecting to having a per eye, just not having them trying to kind of jam all that information into each individual code. So you would have one code that would say blindness, both eyes, and then a separate code to identify the category.
Exactly. I suppose the way I would think of this is almost nobody's going to select these codes without a computer algorithm behind them. As the way the EMRs are doing it. So basically you would do exactly what you said, which is the left eye has category 3, and you don't have to know any of the front end stuff, meaning that's blindness at level 3, and the right eye has low vision at level 1, it's going to pull the code directly. That's how I would envision this working best.
I guess I'm also trying to kind of simplify, not have as many new codes.
I would love to see it simplified if we can accomplish the goal, which was to be able to show change by eye. And that's really what we lost with the current system. And so I think that the new subcategories solve much of your dilemma. I think that for those few people that need the other levels, by reporting the categories, we gain something. I would want to make a comment. I saw a typo, if I'm allowed to. Under H54.12, I missed this. So that whole subsection, we've got the blindness and the low vision in the new codes backwards. And so that's my mistake for missing that. There's too much blindness going on. Please, Shannon.
Jean Yoder, Defense Health Agency. As an analyst, I'm always out there trying to pull data, and so I really like having, you know, if the right eye is always going to be the fourth character, but the problem is, and there are lots and lots of analysts who aren't coders, and so changing everything in each section makes it difficult because you know, and so we say, okay, the seventh character over here means.
But that's where this is perfect. The two digits
the right eye,
are
left eye.
Right,
right eye,
but with that alone, you know all the front end. In other words, all of that verbiage is to deal with the people that actually are not doing this numerically. Because if you put 4-5, you know that that's blindness level 4 for the right eye and blindness level 5 for the left eye. And you don't even need to know the H54 stuff in the front. So they're all in the same position. That is the category of impairments in exactly the same position.
And I saw that and I thought, hey, this is neat, you know.
Oh,
right,
thank you.
Left eye. No, I
dreamed it up on an airplane.
No, because we kind of tried to do the same thing with dental and say, okay, for periodontics, and so each character meant something, okay, and it looks really horrible, but for a code assignment thing, you know, you just say, what's here? It's like TurboTax, chung, 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 bing, and there it is, okay. So, but I still like Nellie's idea of, for the coder that you don't have that electronic record and trying to go through and trying to find this stuff. And, oh well, it's complicated.
Thank you. Hi, Mady Hughes, CMS. I don't know if you brought this up or not, but at H54.2, the title of that subcategory is low vision, and all the new codes have the term blindness.
Yes, so yeah, apparently a second.
Okay, yeah, thanks.
Thank you. Any other comments? Okay, I'm going to turn things back over to Donna Pickett.
Well, believe it or not, we have gotten through all of the proposals. I have to stop. Dr. Linzer is at the microphone.
I'm sorry. This was discussed yesterday, and the Academy wanted me to bring this forward on the Zika virus. Since it is shown to be an in utero congenital condition, we would request that you add a P35.4 for congenital Zika infection.
We can examine that again, and for those who maybe couldn't hear Dr. Linzer, he was talking about the P35.4, correct?
Right.
For the congenital problems noted in the infant. Right now, I think the science is still out on whether there is actually a cause and effect. So we could consider other codes when we have a little bit more scientific knowledge. But right now, our CDC experts are telling us that a code that specifically identifies a congenital problem with absolutely being due to the Zika virus is still under scientific review. But I'll note that when I respond back to CDC on this issue as
We'd
well.
We'd also suggest at P00.2 that a code also note be added if the infectious agent is known.
Okay. Thank you for that. And of course, you'll put that in writing. Okay. Okay, any other comments? Thank you, Dr. Repka. Okay, well, with that, It is 11:15, and we have moved through the proposals expeditiously. We didn't need to worry about meeting lunchtime requirements or the need to leave the auditorium by a specified time, so congratulations to all of us. Again, your time frames for comments, April 8th, for things for consideration for October 1, 2016. And specifically, and hopefully I've got them all, that would be commenting on the Zika virus, the myocardial infarction, the sacral dimple, which was noted by AAP today, and the seroma codes requested and discussed yesterday. We will put a note on the website when we repost the materials so that people know which topics we need to have comments by which date. But again, Zika, myocardial infarction, sacral dimple, and seroma, we would need comments by April 8 for consideration for October 1, 2016. And then for all others, May 6 for those that are being considered for October 2017. And with that, unless I see other burning questions from the audience, I want to thank everyone here in the audience and those who were participating via webcast and by telephone. Due dates for proposals for the March, we are in March, for the September meeting is July 15th. And even though that's a deadline, we do encourage you to get your proposals in sooner if you are able to do that and not actually wait until the July 15 deadline. We're finding that both for CMS and CDC, we're getting proposals, numbering 25 or more on the deadline, and it would be really, really helpful, I think, to both organizations if, as you think about your proposals and can frame them out prior to the deadline, that would be really helpful. It avoids a lot of last-minute changes as well, which I see Mady and Michelle smiling because we all know the issues we've had with this particular meeting with everything coming into us so late. So again, thank you everyone for your attention and contributions to strengthening ICD-10-CM and ICD-10-PCS. Looking forward to receiving your comments and hope to see you all again at the September meeting. Thank you, everyone.
John.